Welcome to American Medicine YouTube channel. This is a health education channel intended for medical students, private practitioners, and other doctors involved in healthcare with the recent topics in medicine. Today we are going to talk about Kawasaki Disease 2024 update. This update came from American Heart Association early this month, which is December 2024. Kawasaki disease first described in 1967 by Japanese pediatrician named Tomisaku Kawasaki. Cardiac sequelae were later documented in 1970. The highest incidence rates are in children of Japanese ancestry. The incidence is 218 to 330 per 100,000 population. The Kawasaki disease associated hospitalization rate in less than 5 years old is about 20 per 100,000 population. There is no diagnostic steps for Kawasaki disease. So the diagnosis of Kawasaki disease is made utilizing clinical criteria. Based on the clinical presentation, it is defined as complete Kawasaki disease and incomplete Kawasaki disease. The Kawasaki disease presents as acute phase, subacute phase, and convalescent phase. In acute phase, the patient will have high spiking fevers, typically more than 39 degrees centigrade, and the febrile phase can last 7 to 14 days. The subacute phase, often asymptomatic period after the febrile episode, it extends approximately 4 weeks. During this period, one can see desquamation of digits, arthralgia, and abnormal lab findings. During this time, the greatest risk for developing cardiac sequelae, such as coronary artery aneurysms. During convalescent phase, typically on asymptomatic period, roughly it lasts for about 4 to 6 weeks after the onset of illness. There is risk of developing aneurysm despite absence of clinical symptoms during this period. The rate of recurrence of Kawasaki disease is about 3% in Japan and 1.7% in the United States. As you mentioned before, it is a clinical diagnosis. There is no pathognomonic diagnostic test. In presence of more than 4 principal clinical features, the diagnosis of complete Kawasaki can be made with 4 days of fever. The diagnostic criteria for incomplete Kawasaki remain unchanged from previous recommendation that was done in 2017. The clinicians are encouraged to diagnose Kawasaki early to prevent dilation of coronary arteries and aneurysms. In this particular 2024 update, Miss C should be added to the differential diagnosis of Kawasaki disease, although prevalence of this condition has decreased significantly since 2022. The important thing about Kawasaki disease during diagnosis, one should be able to identify whether the patient has a standard risk or high risk Kawasaki disease. The high risk criteria are if the patient is less than 6 months old, or right coronary artery or left anterior descending coronary artery Z-score more than 2.5, because the treatment very different or more aggressive in high-risk patients. This slide shows Kawasaki disease evaluation and management. When the suspected Kawasaki disease present in pediatrician office or emergency department, perform lab testing and also inform ID, Rheumatology, Cardiology, and local KD care team, which is available in that hospital. Once the complete Kawasaki disease criteria is met, start IVIG and aspirin and assess for high-risk factors. If there are high-risk factors, intensify the initial therapy, and echo needs to be done 2 to 3 as per cardiology, in 2 to 3 days as per cardiology, and follow the management as shown later in the presentation. On the other hand, if there are no high-risk criteria, reevaluate in 36 hours for fever. If there is a fever, again, intensify the initial therapy and clinical lab monitoring, repeat echo in 2 to 3 days as per cardiology, and management of coronary aneurysms. If there is no fever, discharge home, transition to the low-dose aspirin, no live vaccination for another 11 months, and follow up cardiology within 7 to 14 days or sooner, especially in high-risk patients, and provide Kawasaki education and look for other symptoms. The complete diagnostic criteria are as follows. Fever for at least 4 days plus 4 out of 5 principal clinical features at any point during the illness. Those 5 are polymorphous rash, bulbar conjunctival injection without exudate, which is usually bilateral, odor changes, erythema and cracking of the lips, strawberry tongue, erythema of the oral and pharyngeal mucosa, or all of these, palmar and plantar erythema, usually accompanied by swelling. It resolves with subsequent periingual desquamation in the subacute phase. Cervical adenopathy, usually unilateral, a cluster of nodes more than 1.5 centimeter in diameter, and illness not explained by known alternative disease process. The bulbar conjunctiva looks like it. You can see cracked lips, strawberry tongue, unilateral cervical lymphadenopathy, plantar erythema, and desquamation of fingertips. Incomplete Kawasaki disease diagnostic criteria are as follows. The prolonged unexplained fever and 2 to 3 out of 5 clinical criteria are infants with unexplained fever 7 days and compatible lab or echocardiographic findings. The lab findings such as CR more than 3, SED rate more than 40 or both, or 3 or more of the following: anemia for age, platelet count more than 450K, albumin less than 3, elevated ALT, and increased white cell count more than 15,000, urine WBC more than 10. Echo findings such as Z-score of left anterior descending coronary artery or right coronary artery more than 2.5 or more than 3 other suggestive feature sexes, including decreased left ventricular function, mitral regurgitation, pericardial effusion, or Z-score in left anterior descending or RCA 2 to 2.5. This one enumerates other less common clinical manifestations of Kawasaki disease. There are multiple. It can present like myocarditis, pericarditis, valvular regurgitation, shock, coronary artery abnormalities, aneurysm of medium-sized non-coronary arteries, peripheral gangrene, respiratory, pulmonary nodules, pleural effusion, empyema, and very rarely pneumothorax, musculoskeletal arthralgia and arthritis, gastrointestinal-wise, abdominal pain, vomiting, diarrhea, hepatitis with jaundice, high drops of the gallbladder, pancreatitis, nervous system, behavioral change, irritability, aseptic meningitis, peripheral facial nerve palsy, sensory neural hearing loss, cerebrovascular accidents, syndrome of inappropriate antidiuretic hormone secretion, urethritis, meatitis, hydrocele, phimosis, desquamating rash in the groin, and retropharyngeal glaucoma, anterior uveitis by slit lamp examination. The lab testing recommended in Kawasaki disease or CBC with manual differential, SED rate, CRP, basic metabolic panel, liver enzymes such as ALT, GGT, T-bili, and bad or clean catch during analysis and microscopy. Cardiac evaluation needs to be done by echo and EKG. The high-risk criteria are the patient's 6 months or less, LAD or RCA coronary Z-score more than 2.5 on baseline echo. The differential diagnosis of Kawasaki disease to be considered are as follows. Viral diseases such as measles, adenovirus, enterovirus, and Epstein-Barr, bacterial infections like scarlet fever, acute rheumatic fever, Rocky Mountain spotted fever, leptospirosis, cervical lymphadenitis, toxin-mediated syndromes like Staph-Scaler skin syndrome, toxic shock syndrome, hypersensitivity reactions such as drug hypersensitivity reaction, Stevens-Johnson syndrome, rheumatic head disease like JIA, polyarthritis nodosa, reactive arthritis, acrodynia or mercury poisoning, and MISC. Cardiac imaging in acute Kawasaki. Echo is the primary imaging modality in Kawasaki disease. The imaging stands for echocardiography, has been given in a detailed manner in these 2024 AHA guidelines. And I'm going to show you in subsequent slides. The proximal LAD and right CA are the most frequent location for coronary artery aneurysms. The posterior descending artery is the least common. The Z-score based classification, which was adapted by American Heart Association since 2017, that has been used for evaluating coronary arteries in Kawasaki disease. Accurate weight and height measurements are necessary because any kind of defect or errors in height and weight will affect Z-scoring system. Obtaining an echo should not delay the initiation of therapy, and the normal results do not exclude Kawasaki diagnosis. Normal baseline echo results in the first week of illness do not exclude the possibility of later development of coronary artery aneurysms. Echo should be repeated during hospitalization and before discharge in patients with high-risk clinical features or IVIG resistance. What is IVIG resistance? When there is a persistent or recurring fever 36 hours after the completion of initial IVIG infusion. So how often we need to do an echo? When there is no coronary artery involvement during hospitalization, echo needs to be repeated in 1 to 2 weeks after discharge. If it is normal, again repeat in 4 to 6 weeks. If there is no coronary artery involvement at that point, no need for further cardiac follow-up unless new concerns develop. When the risk level 2 or Z-score between 2 and 2.5, 1 to 2 weeks after hospital discharge, and repeat at 4 to 6 weeks. When the Z-score is more than 2.5, echo needs to be done twice per week during the hospitalization until the dilation or aneurysms have stopped progressing. Then repeat in a week. Myocardial dysfunction with reduced shortening fraction is seen in 20% of the patient at diagnosis and is associated with coronary artery dilation or coronary artery aneurysms. This slide shows various technical evaluations and qualitative and quantitative assessment of coronary arteries of different kinds. Echocardiogram at diagnosis or later shows coronary artery aneurysm, consider consultation with the pediatric cardiologist. At this point, most pediatric cardiology has been most of the time consulted. If it shows small aneurysm defined as Z-score between 2.5 to 5, or medium aneurysm defined as 5 to 10 Z-score, or large or giant aneurysm Z-score more than 10, or absolute dimension of coronary artery is more than 8 millimeter. In all those incidences, start additional anti-inflammatory therapy. Repeat echo 2 to 3 days until coronary artery dimensions have stabilized, and consider echocardiogram, sedative echocardiogram if the patient is less than 3 years. So based on the Z-score, 2.5 to 5, single antiplatelet therapy is enough. When the Z-score is between 5 to 10, dual antiplatelet therapy is needed, like low-dose aspirin and Plavix. When the Z-score is more than 10, in addition to dual antiplatelet therapy, we need to start anticoagulation, consider beta blockade to decrease myocardial oxygen demand, and consider transfusion if the patient is anemic. If the patient becomes afebrile for more than 36 hours and coronary artery aneurysm dimensions are stable by 2 examination or improving coronary artery aneurysms, consider discharging home and with the cardiology follow-up in a week. In addition, for giant aneurysms, echocardiogram needs to be done weekly for first 45 days unless aneurysm size has remodeled to a moderate or small size until the 3rd month after the illness. Then educate about myocardial infarction and do a CPR education to the parents. How to do long-term management, thromboprophylaxis, and medical therapy for Kawasaki disease based on Z-score. I'm going to go very detailed manner. It is all given in this table, but it's kind of hard to see, so you go one by one. When the Z-score is less than 2, that means there is no coronary involvement. We don't need to do a coronary imaging. Antiplatelet therapy, low-dose aspirin for 6 weeks after initial febrile episode, then discontinue. Anticoagulation is not needed, and physical activity counseling needs to be done at every visit. When the Z-score is between 2 and 2.5, that means the coronary artery dilation, it resolves within 6 weeks to 1 year, and follow-up EKG and echo needs to be done 1 to 2 weeks after discharge and at 6 weeks, then 1 year. I may discharge after 1 year if it is normal or otherwise. It needs to be done every 2 to 5 years if the coronary dilation is persistent. This patient needs low-dose aspirin for 6 weeks. If normal, coronaries at 6 weeks, then discontinue. Anticoagulation is not needed, and the physical activity counseling needs to be done at every visit. When the Z-score is 2.5 to less than 5. Again, there are 2 categories. This one falls into small aneurysm. It can be current or persistent or regressive. This is current and persistent if it is there. Repeat the echo in a week and follow up once a week until the coronaries are stable. Then 6 weeks, 6 months, 12 months, and yearly. The stress test needs to be done every 3 to 5 years. Consider CTA at 1 year for baseline, then consider every 3 to 5 years. These patients need low-dose aspirin for 6 weeks, then discontinue. Anticoagulation is not needed, and physical activity counseling needs to be done at every visit. Z-score 2.5 to 5. Here, the small aneurysm regressing to dilation to normal. These patients need to have echo within 1 week, 6 weeks, 1 year, 5 year, may discharge provided stress test and coronary CTA are normal. Stress test assessed every five years. Advanced coronary imaging CTA at 1 year at baseline may consider if there is an inducible ischemia. Antiplatelet therapy, low-dose aspirin is continued until the patient will have normal dimensions. Anticoagulation is not indicated. Again, physical activity counseling needs to be done at every visit. Now, Z-score is between 5 and less than 10, or absolute dimension of the coronary artery is less than 8 millimeter. In this particular category, that is moderate aneurysm, there are 3 subcategories. Medium aneurysm, current or persistent. Echo needs to be done within 1 week, 6 weeks, 3 months, 6 months, 12 months, and yearly. Stress test every 2 to 5 years. CTA at 1 year as baseline and considered every 2 to 5 years. This patient needs low-dose aspirin plus Plavix. Anticoagulation is not indicated. Physical activity counseling needs to be done at every visit. Consider restricting the contact sports such as football, wrestling. This second category within 5 to 10 Z-score, medium aneurysm regress to small aneurysm. Echo needs to be done 1 week, 6 weeks, 6 months, 12 months, yearly. Stress test every 3 to 5 years. CTA at 1 year as baseline, then 3 to 5 years. Antiplatelet therapy, low-dose aspirin alone. Anticoagulation is not indicated, and promote physical activity at every visit. The third category is medium aneurysm regress to normal or dilation only. Echo needs to be done within 1 week, 6 weeks, 6 months, 12 months, every 2 years. Stress test every 4 to 5 years. Coronary imaging, CTA 1 year baseline, may consider if there is an inducible ischemia. This patient needs only low-dose aspirin, no anticoagulation needed, and promote counseling at every visit. The third category is Z-score more than 10, or absolute dimension of coronary arteries more than 8 millimeter. Those are large. Again, there are 4 categories within this subcategories. A large or giant aneurysm, current or persistent. In these patients, echo needs to be done at 1 week, 6 weeks, 3 months, 6 months, 9 months, 12 months, then every 6 to 12 months. Stress tests need to be done 6 to 12 months. Consider coronary CTA within 2 to 6 months. May consider 1 to 5 years, may consider invasive coronary angiography. This patient needs dual antiplatelet therapy with Plavix. Anticoagulation needed in the third categories, warfarin, low molecular weight heparin, or oral anticoagulants. Physical activity counseling needs to be done at every visit. Restrict contact sports and self-limit. Second subset category, large aneurysm regress to medium aneurysm. Echo needs to be done 1 week, 6 weeks, 3 months, 6 months, 9 months, 12 months, then every 6 to 12 months. Stress tests need to be done every 2 to 5 years. CTA at 1 year baseline, considered every 2 to 5 years. This patient need dual antiplatelet therapy with Plavix. Anticoagulation needs to be done either warfarin, low molecular weight heparin, or oral anticoagulants. Physical activity counseling at every visit. Restrict contact and self-limit. Third subcategory is regress, large aneurysm regress to small aneurysm. Echo needs to be done 1 week, 6 weeks, 3 months, 6 months, 9 months, 12 months, than every year. Stress test needs to be done every 3 to 5 years. CTA at 1 year as baseline and considered every 3 to 5 years. This patient needs a dual antiplatelet therapy with Plavix. Anticoagulation needs to be done with warfarin, low molecular weight heparin, and oral anticoagulation. Promote physical activity counseling at every visit. Restrict contact and self-limit. The final subcategory is large or giant aneurysm regress to normal or dilation only. These patients need to have echo within 1 week, 6 weeks, 3 months, 6 months, 9 months, 12 months, then every 1 to 2 years. Stress test every 3 to 5 years. CTA at 1 year as baseline, consider every 3 to 5 years. This patient needs just low dose aspirin. Anticoagulation is not needed, and promote counseling at every visit and restrict contact with self-limit. Let's talk about Kawasaki disease treatment. Again, the Kawasaki disease categories into 2 categories, standard risk and high risk. The treatment, there are 4 folds. Initial treatment, treatment of IVIG resistance, intensification of initial therapy in patients with high risk, and additional therapies. We will go very detailed about this. Initial therapy in acute Kawasaki disease. The main medication for Kawasaki disease is IVIG at 2 grams per kilogram that needs to be infused over 8 to 12 hours. Patients with persistent or recurrent fever more than 36 hours after the completion of initial IVIG infusion are defined as IVIG resistant. IVIG infusion generally well tolerated, but it can cause hemolytic anemia. This hemolytic anemia is a dose-dependent complication of IVIG infusion. It's frequently encountered in patients with A, B, or AB blood group type. IVIG dose should be based on lean body weight. Second one is aseptic meningitis. It is transient and leaves without any sequelae. One should not give live vaccines such as MMR, varicella should be deferred for 11 months after IVIG administration. ESR is usually increased after IVIG administration, so it is not a reliable marker of inflammation after IVIG infusion. The second mainstay of therapy is aspirin. Aspirin is given in the acute period of Kawasaki disease, but its activity on platelets is inhibited by non-steroidal anti-inflammatory drugs, meaning aspirin should not give non-steroidal anti-inflammatory drugs along with aspirin or when you are treating the patient with aspirin. The dose, there are 2 kinds. One, low dose and high dose. The low dose is 30 to 50 milligram per kg per day. The high dose is 80 to 100 milligram per kg per day. It is a part of anti-inflammatory therapy for its antipyretic effect. It should be given till the patient is afebrile for 48 to 72 hours. There are lots of evidence showing that the low dose aspirin is as good as high dose aspirin with less side effects. So currently we use 30 to 50 milligram per kg per day. Low dose aspirin after the defervescence of fever should be started and continued until 6 to 8 weeks after the onset of illness. The dose is 3 to 5 milligram per kg per day. As this table shows, the aspirin 30 to 50 milligram per kg per day needs to be divided every 6 hours. Then once the afebrile period is achieved, then switch to low dose aspirin, which is 3 to 5 milligram per kg per day. Treatment of IVIG resistance. IVIG resistance is defined as persistent or recurring fever more than 36 hours after the completion of initial IVIG infusion. These patients are at increased risk for developing coronary artery aneurysm compared to those who respond to IVIG. There are various drugs that have been evaluated for the treatment resistant. 1. Corticosteroids. Number 2. Infliximab or etanercept, anakinra, cyclosporin. Corticosteroids. IVIG plus prednisone at the dose of 2 mg per kg per day for 5 days. The maximum dose is 60 mg per day while hospitalized. Then pure prednisone 2 mg per kg per day divided every 12 hours. Once the CRP is less than 1 mg per deciliter, corticosteroids are tapered over 2 to 4 weeks with the dose cut in half every 5 days. The dosing based out of Rash trial, which was done in Japan, it has shown the combination decrease incidence of coronary artery abnormalities to 5.9% using AHA criteria and 3.8% using Japanese criteria. This Rash trial was done in Japan in patients of Japanese ancestry. Infliximab, the monoclonal antibody against TNF-alpha, with second IVIG infusion in IVIG resistant patients. The dose given is IV 10 mg per kilogram over 2 hours, one dose. It decreases, shorten the duration of fever, reduce need for additional therapy, less severe anemia, and shorter hospitalization with infliximab. Etanercept. It's a TNF-alpha receptor used as an adjunctive therapy with IVIG. The dose is subcutaneously 0.8 mg per kilogram weekly for 3 doses. There is no significant overall difference in IVIG resistance between two arms. In secondary analysis, there was a lower rate of IVIG resistance in etanercept group in children more than 1 year of age and reduced progression of CA enlargement, coronary artery enlargement among patients with baseline CA enlargement. So it helps. Anakinra. It is interleukin-1 blocker used in IVIG resistant patients. It is well tolerated and associated with the cessation of fever. Cyclosporin is a T-cell inhibitor, blocks calcium-driven calcineurin NFAT, nuclear factor of activated T-cells pathway. Higher rate of treatment resistance in those treated with cyclosporin or incidence of C abnormalities were lower in IVIG plus cyclosporin group than IVIG alone at 2-week time period. There was a higher relapse rate in cyclosporin treated arm, in addition to increased relapse rate and higher rate of treatment resistance. Oral magnesium supplementations also needs to be given when you are treating the patients with cyclosporin. Intensification of initial therapy for high-risk patients, especially when the infants 6 months or less or coronary artery Z-score is more than 2.5 from the get-go. One can treat with corticosteroids along with IVIG, TNF-alpha inhibitors like infliximab or etanercept, or interleukin-1 inhibitors like anakinra or cyclosporin, which we discussed. The corticosteroid dose based on the Rash trial, 2 mg per kg per day divided every 8 hours for 5 days or while hospitalized. Then pure prednisone 2 mg per kg divided every 8 hours, slower over 15 days once CRP is normalized. This patient needs to be given famotidine to prevent gastric ulcer. Instead of prednisone, one can use methylprednisone, often used in North American studies 2 milligram per kg per day divided every 12 hours for 5 days while hospitalized. Then pure prednisone 2 milligram per kg per day divided every 12 hours. One CRP is less than 1. Corticosteroids are tapered over 2 to 4 weeks with the dose cut in half every 5 days. Kawasaki disease with shock. Kawasaki disease can present with low blood pressure, low perfusion, and myocardial dysfunction. It is associated with elevated CRP, hypoalbuminemia, and thrombocytopenia. The hemodynamic instability generally improves quickly once IVIG therapy is administered. Because of the increased risk of IVIG resistance and CA abnormalities, intensification in initial IVIG therapy with second anti-inflammatory therapy needs to be considered. Additional therapies for coronary artery aneurysms. Patients with giant aneurysms that are continuing to progress despite IVIG and other adjunctive therapies, one should consider cyclophosphamide. It should be used in consultation with the rheumatologist. Patients will need to increase fluid hydration while we are prescribing or while the patient is on cyclophosphamide. Second one is statins. Atorvastatin or Lipitor was well tolerated. There were no adverse effects were noticed. Gene expression profiling demonstrated that cultured endothelial cells incubated with sera from patients with Kawasaki disease treated with IVIG, infliximab, and atorvastatin showed improved endothelial health and decreased inflammation. That is the basis for using statins. To date, there is no randomized clinical trials that have been tested with statins. Anticoagulation for coronary artery aneurysms. In patients with large coronary artery aneurysm, there is a risk for luminal thrombosis in both acute and chronic phases. Large CAAs are traditionally being treated with aspirin and Plavix. Oral anticoagulants are potential alternative for thromboprophylaxis with low rates of clinically relevant bleeding and thrombosis. Have fewer drug and food interactions, and there is a reversal agent available named andexanate alpha. Newer oral anticoagulants are not affected by vitamin K intake or as warfarin and do not require therapeutic monitoring challenges. The oral anticoagulants may provide more convenient and safer alternative than warfarin and low molecular weight heparin. The future studies are needed to establish safety and efficacy of oral anticoagulant therapy in patients with Kawasaki disease. As we discussed before, it is given in a table, and when you have a chance, you can go through it. I think we went over this one. Acute myocardial infarction. The risk of myocardial infarction in patients with Kawasaki disease with coronary artery aneurysm is highest the first 2 to 3 months after the onset. The risk of myocardial infarction declines beginning 2 years after the illness onset. There is a persistent ongoing risk of ischemia in patients with large or giant aneurysm throughout the patient's lifetime. Acute myocardial infarction can present with or without STEMI, or ST segment elevation. The STEMI occurs with a sudden complete occlusion of segment resulting in transmural ischemia associated with myocardial necrosis or injury. Non-STEMI will have non-specificity changes, chest pain, and elevated troponin levels. It represents mismatch between myocardial oxygen demand and blood flow, resulting in myocardial injury with elevated troponin levels, without the extensive myocardial necrosis associated with STEMI. The symptoms in children is different from atherosclerotic coronary artery disease angina as we see in adults. The symptoms such as non-specific pain, poorly localized pain, unexplained crying, restlessness, unusual pallor, sweating may be the manifestations. The patient has STEMI. The patient needs to be evaluated and treated within 90 minutes. Percutaneous coronary intervention can be performed if the patient arrives within 90 minutes. Then medical therapy with thrombolysis is recommended. The non-STEMI patient can progress to STEMI, particularly in the first few months after the Kawasaki onset. Medical centers that follow patients with Kawasaki disease with giant aneurysm need to have multidisciplinary heart team and protocol in place to address major adverse cardiac events. When the patient presents with suspected cardiac event, infant children, not specific pain, poorly localized, unexplained crying, restlessness, unusual pallor and sweating, in older children and adolescents, chest, arm, and abdominal pain, breathlessness, vomiting, and discoloration of skin. In emergency department, get the vital signs, obtain IV access, troponin, blood coagulation, and chemistry, get chest radiograph. Go ahead and give aspirin and give oxygen if saturation is low, give morphine if the chest pain, and call cardiologist on duty to discuss transfer the patient to the experienced cardiac surgical center. Again, group into STEMI and non-STEMI. If it is STEMI, if the time to cath lab is less than 90 minutes, urgent transfer to cath lab for percutaneous coronary intervention to re-establish coronary flow. If it is not possible, if the flow is not restored, or the time to cath lab is more than 90 minutes, or not possible because the PCA is not possible because of small patient, consider thrombolysis or CABG. On the other hand, if the patient is non-STEMI, meaning elevated troponin, non-specific STT changes, start heparin, serial troponins, EKG, and urgent imaging with echo and coronary CT angiogram. If thrombus, do PCI or thrombolysis. If stenosis, PCI or CABG if necessary. Once the coronary flow is restored, the post-therapy considerations kind of starting along with the aspirin start. Plavix, 1 milligram per kg daily, max of 75 milligram. And start integralin, 180 mics per kg IV bolus, followed by 2 mics per kg per minute over 12 hours. Continue aspirin, start beta blockers, statin, AC inhibitors within 24 hours. If non-occluding thrombosis is diagnosed, re-evaluate anticoagulation. In a non-STEMI group, for thrombolysis, the pediatric protocol are as follows. Administer TPA at 0.05 milligram per kilogram per hour to 0.1 milligram per kg per hour for 6 to 12 hours. Max dose is 2 milligram per hour. Check fibrinogen more than 150 milligram per deciliter flow. Give fresh frozen plasma 10 to 20 ml per kilo. Then give unfractionated heparin bolus 75 mics per kilo, followed by 20 units per kilo per hour. Check antithrombin 3 levels and replace to maintain the level 80% to 120% of normal activity. Once TPA is stopped, increase heparin to achieve the target activated plotting time of 200 to 250 seconds. Repeat TPA for 2 subsequent days and redose antithrombin 3. To inhibit platelet aggregation, 2B or 3A receptor antagonists may be considered. Now move on to the long-term management. The long-term management of Kawasaki disease based on coronary artery involvement and the maximum Z-score determined at the acute phase of illness. CA dilation typically occurs early in the acute phase of illness, and the maximum CA dimension often occur in the second or third week of illness. The goal of long-term follow-up is to prevent thrombosis and myocardial infarction, and also to provide counseling for optimal cardiovascular health. The patient with persistent coronary artery aneurysm defined as Z-score more than 2.5 after 6 weeks are considered to have long-term arterial damage. Transthoracic echocardiogram is the primary imaging modality for surveillance in Kawasaki disease. It is less reliable in older children and in obese patients because of poor acoustic in windows. Advanced CA imaging, coronary artery imaging, can be done by CTA, coronary CT angiography, cardiac magnetic resonance imaging, otherwise called CMR, or invasive coronary angiography. Coronary CTA. CTA allows visualization of all segments of the coronary tree and can reliably assess CAA, aneurysms, thrombosis, and CA stenosis in Kawasaki disease. The beta blockades may be needed to help lower the heart rate to obtain gated coronary CTA. The coronary CTA is better in detecting distal CAA than transthoracic echocardiogram. Transthoracic echocardiogram is very good in evaluating proximal coronary arteries. CTA is needed to evaluate the distal coronary arteries. CT-derived fractional flow reserve is a simulation technique to evaluate for stenotic lesions. It is often used in adult atherosclerotic coronary artery disease that is being done in children with Kawasaki disease. Another important thing is calcification of coronary artery aneurysms occur late in course of the disease, and heavy calcification can obscure coronary measurements from coronary CTA. The 10% of calcification occurs in 10 years, in 38% in 20 years, and 72% in 30 years after initial Kawasaki disease illness. The coronary CTA may be helpful at 1 year from diagnosis as a baseline to follow a patient with coronary aneurysm, particularly patients with large arteries. It's also needed in patients where coronary artery aneurysm echocardiographic imaging is difficult, including distal coronary artery aneurysm and suboptimal echocardiographic windows. Now those patients having CTA to evaluate coronary artery needs to be done. CMR imaging, it allows visualization of coronary artery and also the ventricular function and tissue characterization without the use of radiation. CMR requires sedation in children less than 8 years. Firmoxetol enhanced coronary MRI has been performed in adults and correlated with invasive catheter angiography to diagnose CA stenosis. The patient who had KD shock syndrome, especially those with myocardial dysfunction, may have increased long-term risk of myocardial fibrosis. These patients benefit from CMR imaging because CMR can evaluate myocardial function and coronary artery. Invasive coronary imaging, it delineates coronary architecture including stenosis, collaterals, and peripheral arterial and internal memory anatomy. It is generally reserved for patients who are being considered for percutaneous revascularization, as we see in patients with acute myocardial infarction, angina, or inducible ischemic stress testing, or in whom advanced imaging modalities have rendered inadequate images. Both intravascular ultrasound and OCT, which is optical coherence tomography, are invasive, and their use is limited as routine surveillance for patients with Kawasaki disease based on the availability of the test and also availability of the skillful providers. Assessment of inducible ischemia. The indication those who are at risk for stenosis and obstruction. And coronary artery aneurysm with Z-score more than 10, particularly those with Z-score of more than 20, those with complex architecture, or luminal narrowing more than 50%, or those who have coronary artery thrombolysis. The exercise stress echocardiography does not involve radiation exposure. It is preferable to positron emission tomography and stress nuclear imaging. CMR imaging, useful imaging modality without radiation, especially in children who are too young to exercise. Stress echocardiography is more physiologic than pharmacologic stress testing. Children who are too young to exercise should use dobutamine to perform stress exercise protocol. Exercise stress echocardiography can be performed in children more than 7 years of age and used as a screening tool for assessment of inducible myocardial ischemia. Now we moved on to transfer the healthcare from pediatric to adult. The key element of successful healthcare transition, you need to have a structured intervention that incorporates the components of planning, transfer, and integration into adult care. This one concludes Kawasaki Disease 2024 update. Thanks for listening. If you like this, please like it and share it with medical students, postgraduate students, practicing physicians, and pediatric cardiologists. Appreciate your time, and we will see you in next seminar. Thank you so much.